So a very warm welcome to everybody. Good evening to all. So we come to the seventh of the series of webinars that we've had on the research methodology. And it has now become customary for me to thank Dr. Lakshmi. She is the ICOG chairperson, and she took this very bold step to have this, research methodology series. Again, that's a very important bold step which has slowly gathered momentum. People have now got interested, and we have now a sizable, respectable number of about 70 plus in each of our every webinar. So we started from the study designs, the various types, then we went on to biostatistics, the research, then the systematic reviews, publications, and today we are on to the guidelines development. So this is the program for the day. So we have Dr. Lakshmi, who is a very revered and very respected person in the FOGSI office. So as you can see, the entire slide is filled with her achievements and her accolades. So request you, Dr. Lakshmi, to please share the, speak a few words.
Thank you so much, Dr. Radhika, and very good evening to one and all. And as Radhika said, it is also customary on my part to thank the course convener, Dr. A.G. Radhika, because I only conceived and it is she who actually delivered these all the 7 episodes of this research methodology web series. And today was her idea only to come out with one webinar on formulation of clinical practice guidelines. So I was just searching and why need clinical practice guidelines and what are they? So just to tell you, they are the recommendations on how to diagnose and treat a medical condition. So it is very, very important for us. But as I was discussing with Radhika, it really requires a rigorous steps, and she was telling me, no, it is not that hard, but I know it requires formulating the key questions, the evidence retrieval and synthesis, appraisal of the quality of the evidence, and once you form it, they should be feasible, measurable, and achievable. So yes, it is a task, but not that difficult according to Dr. Radhika. And we do need clinical practice guidelines when we are practicing, whether in public sector or private sector. So I place on record my sincere thanks to our FOGSI President, Dr. Rishikesh Pai, Secretary General, Dr. Madhuri Patel, and all the FOGSI office bearers, along with the Jogi office bearers, the Editor-in-Chief, Dr. Geeta Balsarkar, the Editor Emeritus, Dr. Suvarna Khadilkar, for their constant encouragement, support, and guidance. And of course, I appreciate the efforts of our Vice Chair, Dr. Parag Biniwale, Secretary, Dr. Ashok Kumar, and our course convener, Dr. A.G. Radhika, along with course coordinator, Dr. Vaishali Kode Nayak, and Dr. Ranjana Sinha. And I really wish to welcome and appreciate today's co-convener, Akhilesh Ramaswamy, who is from Jipmer, Pondicherry. And I take this opportunity on behalf of ICOG to welcome all our speakers, starting from Dr. A.G. Radhika, Dr. Malavika, who is logged in from USA. She will be covering 2 topics, and Dr. Joseph Matthew, who is from PGI Chandigarh, who will be again taking 2 topics for all of us. And I also welcome all our esteemed chairpersons, Dr. Achla Batra, Dr. Madhuri Patel, Dr. Maninder Ahuja, Dr. Sheila Mane, Dr. Jaideep Malhotra, and Dr. Ambuja. So dear delegates, wish you all happy learning, and let us learn from all the experts about how to formulate the clinical research guidelines. So happy learning, and I hand over back to Radhika for further proceedings.
Thank you, Dr. Lakshmi. So we go on to the next few introductions. So that's me. Incidentally, now we have the Association of Obs and Gynae Society of Delhi, the offices at UCMS. So I just also got the position of the secretary. Incidentally, I just wish to say that all the speakers today, including myself, we belong to the Guidelines International Network. We are members of the Guidelines International Network, and everybody has been holding very important posts that we will see as we go through the program. So I'm very happy to have also Dr. Vaishali Kodinayak. She is the coordinator of the program. She is the professor and head of Mymar Medical College, Pune, consultant critical care obstetrics, Ruby Hall Clinic at Pune. And she has also been the fellow of the maternal and fetal medicine, NUS Singapore, university examiner for UG and PG exams. So as we can see that she has had a lot of credit given to her for her good work. Then we also have Dr. Ranjana Sinha. She is a chief consultant at the Gynae clinic at Patna, former head of the Gynae department at East Central Railway, Patna, executive member of ISOPAP 2022-24, former joint secretary ISOPAP 2020-22, and co-chair of the practical ops committee of the Patna Obs and Gynae Society 21-22, and she's received the national award for outstanding service in Indian Railways by Government of India 2016. So we go on to the first session now. I request Dr. Ranjana to please start.
Thank you very much, ma'am. Good evening, respected faculty members and dear participants. Continuing our FOGSI ICOG Jogi web series on research methodology, today our topic of discussion is formulation of clinical practice guidelines. And to discuss all the important aspects of the topic today, we have a galaxy of eminent speakers and very learned chairpersons to add their expert comments. So beginning our first session, let me first invite our chairpersons. First, I would like to invite Madam Madhuri Patel. We are really honored to have you as our chairperson today, ma'am. Thank you, ma'am, for sparing your precious time out despite your busy schedule. Madam is, as all of you know, is a very hard-working Secretary General FOGSI. Madam has also been Joint Secretary FOGSI in 2009, and Madam is also former committee member FIGO preterm birth. Madam has more than 50 publications, and Madam is also honorary clinical associate at Envadia Hospital and Police Hospital, Mumbai. Madam is visiting consultant.
Thank you, Ranjana. Thank you, Ranjana. You can
okay. So I welcome you, ma'am, as our chairperson. Next slide, ma'am. Next, we have Dr. Professor Achla Batra from Department of Obs and Gynae, VMMC and Safdarjung Hospital, New Delhi. Madam is President, AOGD. Madam has also been President.
This is the old CV. Dr. Amita is the President, AOGD.
Oh, extremely sorry, ma'am. Okay. Madam has been President Narshi Delhi Chapter 2018-20, and Madam has been Chairperson Euro Gynae Committee AOGD 2019-21. Madam has held many important posts in Narchi and AOGD, and Madam has dedicated PG and UG teaching for 35 years. Madam has conducted many research projects for LSTM, ICMR, and Indo-US projects. Madam has also authored many books. Madam is reviewed in national journals, and Madam is also Madam has contributed to several MOHFW guidelines. Welcome, ma'am. And finally, we have Professor Maninder Ahuja. Madam is President, Society of Meaningful Life Management. Thank you, ma'am, for logging in from LA, USA, despite being on a vacation. Madam is also Director, Ahuja Healthcare, Dental and Infertility Clinic. Madam has 40 years of dedicated work for women from adolescence to menopause. Madam is SAFOMS VP since 2018 and has been Secretary General SAFOMS from 2014 to 2018. Madam has also been VP FOGSI 2013-14 and President IMS. And Madam has been Editor-in-Chief JMH, is Editor-in-Chief JMH 2022-2014. Madam has more than 100 publications, many awards and felicitations. With this, I welcome all our esteemed chairpersons to the virtual dais. I also request all the participants who have joined in today for any queries, they can put it on a chat box. And with this, I hand over the session to our esteemed chairpersons and request Dr. Achla Batra ma'am to kindly invite AG Radhika ma'am.
It's a real pleasure to invite Radhika, with whom I've been associated for I don't know how many years. And I've seen her grow from a student to this prestigious position now. And I don't think I need to tell that what all she has done. She has been member of Cochrane Corporation, Campbell Corporation, Geneva Foundation, has received many awards, has also got the ICOG Visiting Professor Awards, Korean Awards of FOGSI, Best Paper Prize, and has been a WHO Fellow, has been a reviewer for Cochrane Collaboration, Yogi, IGMR, CEFOC. So I think she is the correct person to talk about, how we make guidelines and how important are guidelines. We all must know because we have to follow them. So we should know what we are following, how much effort goes into making them. So over to you, Radhika.
Thank you so much, madam, for that very generous introduction. So my job is going to be the easiest today, and I'm just going to be talking about the overview of the clinical practice guidelines. So, the point is, the reason for having this session today is because we are still in the very basic stage here in India, especially in the field of obs and gynae. So we just wish to make it, unravel the mystery and not make it appear like one very tedious process. Of course, it requires a lot of input, but not so difficult. Being a lady and being a gynecologist, we have achieved what majority of the people in the world may not have been able to achieve. But this is, I think, something that is very much required for us and for the country. So basically, clinical practice guidelines give us some kind of recommendations about the health interventions. This could be in the direction of clinical, public health, or policy interventions. And here it is, this is after taking into account the available evidence, the certainty of evidence, and also the robustness of the available evidence, and along with the value judgments which are incorporated by the clinician, and also keeping in mind the available resources. And of course, elucidating the benefits and harms, including the alternative care options. So there is a systematic review that is undertaken of the research evidence on a clinical question focused on the strength of evidence. This determines the clinical decision making. So guidelines, mind you, are suggestions and they are not rules as opposed to the policies which are kind of binding. So these could be, legislations or acts, the recent MTP amendment as well as the ART acts. These are some of the examples. So guidelines are basically suggestions. And most importantly, when you have a similar standard practice here, it also gives us a good idea as to how good we have been in delivering what we thought was good for the patient. Meaning, it's a good way to audit one's own practice. And when you have it over across the country, it also, I think, becomes extremely useful for us to audit and also assess our own work. However, it is also to be noted that there will always be an individual patient who may require to be managed differently. And how we do that is something that we will just see in the next few slides. So the basic steps which I'm going to be quickly going through, because the rest of the session is based on this exactly. So you scope a guideline, you identify the point or the important area where you wish to have the guideline for, set up a guideline development group and an external review group. The declaration of interest and the management of conflicts of interest are important. And then the PICO question is formulated and choose the relevant outcomes. Then you have a guideline recommendation committee, which has the approval of this guideline proposal, development proposal. This is followed by the evidence retrieval and the assessment, as well as the critical appraisal and the synthesis. And the grade evidence profile is a software. This is basically the grading of recommendations, assessment, development, and evaluation. And basically to identify the certainty of evidence and the strength of recommendation, and the various aspects which are included for grading the evidence are the benefits and the harms, the values and the preferences, and the use of resources. And the guideline review committee finally gives approval. So then finally this is disseminated and implementation comes into practice. Evaluation of the impact is extremely important, and the plan for updating is the most important part of a clinical practice guideline. So there could be various types of guidelines. So this is the what we just saw was the standard guideline, which is a full systematic review with the guideline development. Could take anything from 6 months to 2 years. There could be rapid advice guidelines like we saw during COVID era. So it's an abbreviated process, could be anything from 1 to 3 months. However, there could be potential for bias because we are doing everything very quickly. So including the literature search, so collation of evidence as well as critical appraisal could be to a certain extent not possible in such a short time. So there is a possibility of a bias. So interim, the process of giving an interim guideline is similar to the standard of the rapid advice guideline. However, the scope is very narrow. It has got a short shelf life because it needs to be followed up with a standard guideline. There is today something called the appropriate use criteria. Now, this appropriate use criteria is basically for addressing the problems that we face as a clinician on an individual patient. So it is tailored as much as possible to the specific characteristics of an individual patient. And the implementation today, they have also developed calculators and tables for the clinicians to input the specific patient information to get some kind of recommendations for the practice, the clinical practice. So then there are also the guideline statements which are based on the reviews of other guidelines, and these are not basically through the systematic review of evidence. Now, how has it been like? Today we say that we are still in the nascent stage of development in the field of obs and gynae, because other fields like the pediatrics, Dr. Joseph is here, orthopedics, anesthesia have done a little better, but we still need to gain. But what has happened to the world? So this was a publication in Lancet in 2007. So how much of the WHO recommendations are through the use of systematic review and the available evidence? So before 1951, around 1951, it was WHO regulations, and these were basically through the expert opinion. In 2003, WHO also rose up to this fact that collating the evidence is extremely important. So these group of authors, they examined the use of evidence, particularly the evidence of effects, in recommendations developed by the WHO departments. So they went through a series of interviews of the departmental directors in the WHO headquarters. And what they found was the systematic reviews and concise summary of findings are rarely used for developing the recommendations, and it greatly was affected by the presence of experts in the specific specialty. Later in date, this was in 2021, the research article was titled, "Over half of the clinical practice guidelines use non-systematic methods to inform the recommendations." So here too, the authors, this was published in PLOS One in 2021, and they found that 34% of the guidelines were systematic in their approach to evidence synthesis, and 2/3 of the guidelines were non-systematic. So how are we doing in India? So this was a paper that we published in 2018. So we went through the literature, through the publications to identify the guidelines that were published in India. And the two of us authors, we filtered them, used relevance, clarity, and the appropriate use of health resources to filter and identify the ones which could be eligible for the appraisal. And the appraisal was through agreed to standard scale, which is published in WHO. So we came across 70 guidelines, and we filtered and got down to 47. And when we applied relevance, clarity, and appropriate use of healthcare resources, we finally came down to 8. Of these 8 guidelines, what was the agreed to scores? Majority had a good scope and purpose. They were clear about the objective of why they are trying to develop this guideline. But what was really lacking was the editorial independence. None of them actually talked about there was no declaration of interest. There was no clarity with respect to the conflict of interest. The clarity of presentation was also not exactly very good. The applicability really got lost in the process of developing these guidelines, and the rigor of development was extremely poor. So this was what we saw, and we had published. In fact, this was an awarded paper at FOGSI, and I was the proud recipient of the FOGSI Award, Korean Award, for this paper. But then nothing has really changed after that. So what is a trustworthy guideline? The process has to be transparent, as has been already highlighted, especially the funding process. So where you have a pharma company supporting the guideline, we need to be careful when we understand what is happening. So then it has to be developed by a multidisciplinary panel. Rigorous systematic review is extremely important. disclosure and management of financial and non-financial conflicts of interest is important. And there has to be a clear clarity in the guideline recommendation. Rating of the level of evidence is also to be provided for the reader to understand the level, because one might actually have to use a lesser recommended guideline because of the lack of resources, but one must also know at what level, especially when you are talking to the patient and also telling them about what you are planning to do. It's important to have an external review, and also sometimes it is a good idea to open it for the public comments. And there has to be a mechanism for revision and updating of the guideline. So thank you so much. Thank you so much for the patient hearing. So the rest of the session is going to be actually the actual sweet, the actual part, the cake. So thank you so much.
Thank you, Radhika ma'am. And may I request Madhuri Patel ma'am to comment on.
Unmute karo, Dr. Madhuri ko, Gauri, co-host banao.
Yeah. Dr. Radhika, it was an excellent delivery, and we all, when we sit together, only the academic part, people take interest in that. But now what I'm seeing, even the private practitioner who are not the teachers or the professor, they also take part in this. And the formation of these clinical guidelines are very, very important, because these clinical practice guidelines are, recommendation on how to diagnose and treat the medical condition are mainly written for the doctors. But what we have observed, it is also meant for some of the health workers. They are also their guidelines. And Radhika has, done it so beautifully that what is required. The most important, she said that we have to formulation recommendation from both health intervention, clinical, public health or policy intervention. So she gave those 6-7 points. They're very, very important one. I want to give only one message, that when you follow this recommendation, because in a FOGSI, we have a good clinical practice recommendation. We don't write down guidelines. Every countries, they have a guideline, but we are switching over to the good clinical practice guidelines, recommendation. The reason is that in case there is some, we have to appear in the court of law, then, if you write a guidelines, then it is many times bound to that. So therefore, we have changed to good clinical practice recommendation. You have to follow. And if you don't believe, if in your experience you don't believe that these are not the good one for my patient, then you have to have explanation why you feel that this is not fitting to my patient, because each and every patient is unique. But usually we follow these good clinical recommendation, and these good clinical recommendations are to be updated. You can't have 2015 what has happened or 2010. So in FOGSI, we are doing this good clinical practice recommendation. Dr. Lakshmi has pointed out in one of the guidelines, good clinical practice recommendation, that it is 2015, it was done. So unless you update, our clinician who are there as a member, they cannot follow it. So we have to update on and off. And we have to give the message to all our members that these are the guidelines. Please stick to that. We cannot protect you in the law of court, but at least we agree, because many times they take two opinions. When there is a problem, medical legal issue, they took two opinion of the other obstetrician and gynecologists. Was the doctor was correct or not correct, And those obstetrician and gynecologists, if you are sticking to the GCPR guidelines, they are going to, give the same opinion what the doctor has followed the guideline. So it is very, very important to have guidelines, or what you say, good clinical practice recommendation. And for that, how it is formed, has to be scientific, evidence should be there. Then you can follow everything. So thank you very much for giving me this opportunity. And Radhika, it was excellent. And Lakshmi, you are doing, I must talk about Lakshmi. I think I was going through all the things, and in 7 months, she has conducted, this is a 7th series. Yes. She is doing. Apart from that, she is doing other, what you say, journal club, then, many things she is doing. And every month, I think there are 10 webinars or 12 webinars are fixed. So in 7 months, she has done almost 70 webinars or up to 80 webinars, and this is really good. And she's doing collaboration with Jogi, that is also very, very important in research methodology, because we all are there. She's also, review committee member, and and we are also there. So it is really helping each other. And of course, Maninder and my co-chair Achla, they're also fantastic. And here, all of you have joined, Dr. Ambuja. Thank you very much for giving me this opportunity.
Thank you. Thank you so much, Madhuri, for sparing your valuable time and giving your expert comments. Thank you.
Thank you. Thank you, Madhuri ma'am, for your pearls of wisdom. And now I would request Dr. Maninder Ahuja ma'am to kindly introduce our speaker, Dr. Malvika Tampi.
Good morning from LA and good evening to all Indian my colleagues. I think I must have to say thanks to Lakshmi for conducting these, but more to Dr. Radhika. I think I have been after her for so many years that we should be conducting these series on research methodologies, which is very, very much required, because a Greek philosopher said, Heraclitus, his name was, that the only constant thing is change. So when the change is there in everything, in not only science, in our psychosocial circumstances, economies, our changes, behavior, everything is there. So that has to be then science-based, evidence-based. And evidence-based, then we have to do these recommendations or guidelines. As Madhuri rightly said, we are doing recommendation. We are not planning guidelines, because that needs robust evidence, which is sometimes takes 1 to 2 years to develop also. And secondly, as Lakshmi also has pointed out, and Madhuri also, that we have to update these recommendations. At least we should make it a rule that every 2 years, we should be updating them, because the evidence is changing a lot very quickly. And it's my proud pleasure to now welcome Dr. Malvika Tampi, as we happen to be from the same country, sitting in the same country at this time. She is the Masters of Public Health degree from University of Michigan School of Public Health, and employed by Alzheimer Association, Chicago, Illinois, USA, and previously worked for the Infectious Disease Society of America and the American Dental Association in guide development, member of the GRADE Working Group, Guideline Development Methodology Group, and the Guideline International Network, and previous collaborations with PAHO and WHO and Cochrane collaboration. 2021 recipient of Guidelines International Network's Innovation Award for Individual Excellence in Clinical Practice Guideline Development. So she is the right speaker for the topic on planning a clinical practice guideline, steps to follow, and how to create the evidence retrieval, synthesis, and assessment. And it's all to you, Dr. Tampi, Malvika Tampi. Welcome to this webinar, and we are very, very keen to listen to you, because that is what is required for all the gynecologists, whether they are in practice or they are in medical colleges. Welcome to you.
Thank you, Dr. Ahuja and Dr. Radhika and everyone here who has been
She's
so warm
muted.
and welcome. No, can you hear me?
Yeah, we can hear you.
Okay,
We can.
okay. Thank you so much for the warm welcome and for having me. I really appreciate being here, and I look forward to hearing from all of you as well. And I welcome any questions. Just please stop me if you have any questions, or put them in the chat, and I can try to get to them at the end of the presentation. I do have to, it's the beginning of my work day, so I do have to go to work, but I'd be happy to answer any questions via email as well. So I'm going to share my presentation. Just give me 1 second, please. Okay, can everyone see the slides?
Yes.
Okay, great.
Just make it, yeah, great.
So my name is Malavika, and I'm joining you today from Boston. I'm here for a course on dementia. I work for the Alzheimer's Association, so this is a new position for me. So I'm orienting myself to this new clinical field. It's very exciting. A lot of updates in treatment options, diagnostic tests, that are coming out here in the United States. So I'm learning as well, and really guideline methodology and the field that I am a professional in it's constantly changing, and then moving from clinical field to clinical field, it's also very interesting. And so I'm very happy to be talking to esteemed gynecologist and within your association today. And today I'm going to be talking about Introduction to Clinical Practice Guideline Process and Methodology. Dr. Radhika did an overview of what guidelines are, and I have a few slides on that, so I will keep those very brief. But really, and you already know all of this information, but really what I wanted to cover today are the basics of guidelines, and specifically focusing on process, resource needs, as well as the methodology used, which is across most of the world, or most major organizations, really the move is to something called the GRADE approach, which is an approach for developing trustworthy systematic reviews and guidelines, and specifically steps on how to formulate scope, purpose, target audience, as well as developing clinical questions that are called PICO questions, which I will get into. The very basics of conducting or using systematic reviews. It's great to know that you all had a session already on that, but I will just keep it very high level on why and how to use systematic reviews for guideline development. And Dr. Joseph will get into that a little bit more in his evidence decision framework lecture, how to compile evidence in evidence profiles for panel decision making. And I will dive right in. So what are evidence-based clinical practice guidelines? Dr. Radhika touched on this. They're a type of policy developed by usually healthcare associations, trusted organizations, I should say, and in collaboration with guideline panels and patient partners. And this emphasis on working with patients, either on the panel or a focus group, or collaborating with a patient partner organization, has been one of the newly emphasized components of guideline development. And a lot of fields here within the United States are exploring how do we include or incorporate patient perspectives into the guideline development process. Guidelines are designed to assist evidence-based clinical decision-making informed by the best available evidence collected and synthesized using a systematic review, and consider not only the evidence, but clinical expertise of the panel members, as well as their representing their colleagues, as well as patient values and preferences, and other key factors for decision-making, including accessibility and feasibility of the available options, treatment options, or diagnostic test options. They often inform public health programming and are designed to improve outcomes, but also standardize care appropriately and de-implement harmful interventions and tests. So as it was earlier mentioned, evidence does not dictate clinical practice, and I wanted to provide one example to highlight this. There was a guideline done several years ago on screening with mammography for breast cancer, and 2 different countries used the same evidence to develop clinical practice guidelines on the matter. One was Saudi Arabia, one was Switzerland, and both of them, using the same evidence, provided 2 different recommendations for the implementation of mammography. And Saudi Arabia thought the benefit the evidence showed that the benefit was small. That's how the guideline panel interpreted the evidence, but they put a higher value on the beneficial outcomes. And so they provided mammography to a large proportion of the population that they were interested in, versus in Switzerland, the benefit and harm ratio was more equal. They could not justify the benefit and provide mammography more readily. So to avoid unnecessary procedures and costs for the health system, they decided that the benefits do not outweigh the harms, and they were more stringent with the availability or recommending for mammography for breast cancer. So this is just an example how the same evidence can dictate, the same evidence does not necessarily lead to the same guideline recommendations across multiple contexts or settings. It's really based on the values and preferences of the people who are developing the guideline and the patients that they're representing. Now, this is a slide that I have some understanding of, meaning working understanding of, I worked in dentistry for the American Dental Association. There are multiple evidence ecosystems across multiple clinical specialties, and this is just the one I have participated in, so that's why I'm sharing this as an example. So evidence ecosystems are very important in the guideline development process because they really allow us to optimize resources and also include the right people during the process. So we have all of this amazing primary research coming out, some research better than others, but really we have also experts in evidence synthesis who know how to synthesize this evidence and really piece out what are the appropriate studies to include and what are not, and they can guide that process. Those products, evidence synthesis products, usually systematic reviews, are what are used for guideline development because of their systematic, comprehensive nature. And then, of course, we have this update, implementation, evaluation process that should be in place to be able to create this feedback loop to improve the policies and guidelines that are in place for patient care. It's very, very important. And in the middle, you see digitally structured data. That's something I will touch on as well. It's the importance of using systems that allow you to collect data, reducing error and bias, and being able to house the data in a way that you can easily update it when the time comes. So this is just, again, a dental example. I would encourage you to consider what is the evidence ecosystem that is present or available or can be built in your field. I pulled this from the same website that Dr. Radhika shared. So I won't get into all of the steps, but I just wanted to outline for your future reference what I would consider the key steps in the guideline process. Of course, there's prioritizing the topic, convening the panel, assessing, managing COIs. Usually what I do is I host a panel meeting to define the scope, purpose, target audience of the guideline, as well as select the clinical questions and the selection criteria for the systematic review. And either we conduct our own systematic review or we use pre-existing systematic reviews and potentially just update them. Again, that reduces the resource burden. Once the review is done, evidence tables, evidence profiles are created to be used by the guideline panel, usually facilitated by a methodologist. I'll get into that in a second. And then stakeholder engagement, as I mentioned with this slide, all of the players in the field, who needs to be at the table, those people need to be contacted, the recommendations shared with them so that they have an opportunity to weigh in and provide their feedback. And usually when I was working at the American Dental Association, the process there was that we would contact stakeholder organizations after that first panel meeting to share the scope of the project, gather their input, share with the guideline panel. Doesn't necessarily mean we take all of their input. It's just an opportunity for them to see how do my peers, how do my collaborators within this clinical field feel about the direction in which we are headed. And then again, obviously after the second panel meeting, once the recommendations are formulated, providing an opportunity for those stakeholder organizations to provide, including patient organizations, to provide feedback. So then the panel is fully informed of how, as informed as possible of how people will respond to the publications once they come out. One of the criteria, quality criteria too for guidelines includes providing an opportunity for the public to comment. Sometimes when we're developing guidelines, we have this very narrow focus of this person's important or that organization is important, but these are going to impact so many people. And so providing an opportunity for the public to comment as well is a great way for the panel to have information that might alter some wording in the recommendations or provide a perspective that could potentially change the perspective and potentially recommendation as well. That usually does not happen, but that it really has in the past provided me useful information on wording changes within the recommendations to make it more clear and actionable so more people can understand the recommendation. There's no point in developing recommendations that only experts can understand. People need to be able to read it and understand it. And then finally, a review and peer-reviewed publication. And Dr. Joseph will get into the second half of these key steps. So when we're talking about major resource needs, as I mentioned, this is the first step. Who do we have on board? Who are we working with? And what technology or external evidence evidence-style resources do we have to develop this content? And when we talk about personnel, the guideline panel is the most important piece of the puzzle. They are really the clinical and subject matter experts that need to be convened to be able to develop the guidelines recommendations. Usually there's a chair. Sometimes there are 2 chairs, depending on how big the guideline is. You can split up part of the scope of the project, half of the clinical questions for that person, and then the second half for the other person. I tend to prefer 1, so there's 1 centralized decision maker or person facilitating the process. But again, it really depends on the needs of the panel. And usually there are about, I would say 10, max 15 to 16 people. The more people you have on a panel, the longer decisions take. So keeping the panel manageable is very important, but again, based off of the expertise that is needed for the topic at hand. So really considering what are the types of questions that we want to write and who needs to be at the table to be able to speak knowledgeably to the evidence we will collect and use to make our decisions. And so the panel needs to be comprehensive. This includes support teams. So if there are physicians on board, that's great, but consider, are there nursing professionals or other types of support team roles? And that's not the correct terminology. Please use whatever is appropriate for the people that you will be working with, so they don't feel less than, because everybody on the panel is equal. So really encouraging that a consensus-based process, allowing everyone to feel like they have a voice at the seat, not in a necessarily in a hierarchical manner, is very, very important to make sure everyone feels comfortable enough to be heard and then decisions be made. But again, if, for example, a certain professional is actually administering the test, really consider, should they also be at the table? Or is it really, at the highest level, we only need the, a specialist on board. We don't need the primary care physicians on board. That should be a conversation. Please don't assume that the highest level of expertise is the appropriate level of expertise for a particular topic. Then there are the methodologists. And so those are people like me who don't have any commitment to any one particular clinical topic necessarily. Some people do specialize in their area of study. Like Dr. Radhika, she is a methodologist, but she's also a gynecologist, obstetrician. So potentially these are the guidelines that she wants to help manage and lead. But for people like me, we're growing. There are more and more people interested in this field, which is amazing. But it's very important that you have a guideline methodologist on board to help guide the panel, because they are objective and really know how to use the evidence in a way, or present the evidence in a way to the panel to help them make their decisions. And then, of course, technology. I'm not going to get into all of this, but I put it on there for future reference for you all. If you're interested, I'd be happy to answer any questions, but really you need to consider for the systematic review, what software do we have to distill the evidence and synthesize it, manage our references, and then move from evidence to decision, and also analysis. So if you're doing a systematic review, you need usually, if you're doing any quantitative analysis, meta-analysis, you need that software. So, and of course the evidence. So what library resources do you have? And I would encourage you to work with a librarian if you are accessing library resources, so the search can be systematic and comprehensive. Now, grade methodology stands for Grading of Recommendations, Assessment, Development, and Evaluation. And this is the premier methodological approach that is used by guideline developers to move from evidence to decision or recommendations. And it's a transparent framework for developing and presenting summaries of evidence, and provides a systematic approach for making recommendations. And it is the most widely adopted tool across the world, including the WHO uses this methodology or framework. And something that Dr. Radhika had mentioned is ensuring that the scope is appropriate. Sometimes it's appropriate for the scope to be broad. less useful for informing clinical practice. So since we're talking specifically about clinical practice guidelines, what do you do in the clinic to inform patient care? I would suggest that you consider narrowing down your scope and splitting your questions into specific distinct interventions and comparators that will allow you to provide a specific answer that is clear and actionable once you're ready to formulate recommendations. And this has a better applicability when informing clinical practice. Now, I wanted to also highlight that there are a range of resources available to all of you online that explain grade. And one I will just share here is the paper, the second in a seminal series of articles on grade published in the Journal of Clinical Epidemiology that describes how to frame clinical questions and decide on important outcomes. Because these questions, these PICO questions, these clinical questions are the foundation by which all of the systematic review work, as well as the guideline work subsequently, is built upon. Now, this diagram shows PICO questions move into systematic reviews, moves into guidelines. And one of the key questions to ask yourself is, how do you write good PICO questions? It's very, very important that they are written in appropriately. And again, this is where guideline methodologists can help you and support you in ensuring that the panel can kind of come to an agreement and move forward in the most effective way. And background questions are questions that potentially a medical student would have on the background of screening for breast cancer. That necessarily isn't the right question for a systematic review in a guideline. You may want a more specific question for what patients is it appropriate to screen using this test or this tool for reducing or for increasing early detection of breast cancer. That might be a more appropriate question to ask for a systematic review. And so it's very important that you ask foreground questions when you're developing systematic reviews and guidelines. Again, someone can help you do that. They should reflect the scope and purpose of the guideline, and they should guide the systematic review process. And really, the clinical questions are the questions that are answered by the recommendations. And I will show you an example in a second. So PICO questions should be written in the PICO format. I know you've had your session on systematic reviews. You've probably covered this, but just to be very brief, they should include all relevant outcomes for decision-making. This includes critical and important outcomes, which I will show you again later, and they should be relevant for the target users. And by building a comparison, you're providing all of the most critical or relevant options for the decision. So then people can say, if you're recommending for this test versus no test, you know that the comparison is no test, not another test. So the decision-making is much more clear for the panel and for clinicians and other users of the guideline when you have your PICO questions in a comparison format. I won't get too much into this, but PICO, Patients, Interventions, Comparators, Outcomes. Please take a look at this slide when you are developing your PICO questions. It might be useful in helping understand or help guide in the PICO writing process. Now, I tried to find systematic reviews within your field to maybe illustrate what the PICO format looks like. This was a systematic review published in 2013, which is old, but I just wanted a basic example that might be of interest to all of you. And so this is from a Cochrane systematic review on acupuncture for menopausal hot flushes. And as you can see here, based off of the little paragraph there on hot flushes are the most common menopausal vasomotor symptom. You can read that yourselves, but the PICO has been kind of broken down for you. P are the symptomatic peri or postmenopausal women. Acupuncture is the intervention, comparators, no treatment, control, or other treatment. So they're offering all of the options that the data could, of which we would want to collect data to then formulate recommendations based off of what those comparators are. So you could technically write this as 3 different PICO questions. It could be PICO question, no treatment, PICO question, control, PICO question, other treatments, and then listing out what those treatments are. So multiple PICO questions, but for the sake of this, I've just included it all together. And usually this is how I present it in the guidelines rather than having multiple PICO questions. It it's somewhat summarized here, and then you'll have multiple separate recommendations appropriately designed to help, again, guide clinical practice. And both outcomes are included. I think these are probably both critical outcomes: reducing hot flushes and improving quality of life. Those are the most important for patients when making the decision, for when the doctor is making the decision with them on whether acupuncture should be implemented or not. And when you're developing clinical questions and running analyses, you can have pairwise meta-analyses or network meta-analyses. I won't get into this, but really there are different statistical options for analyzing the data and providing the information the panel needs to make their decisions. So this is, that PICO question gets translated into this question that the guideline panel answers to formulate the recommendation. So for symptomatic peri or postmenopausal women, should we recommend acupuncture versus no treatment control or other treatments for reducing hot flushes and improving patients' quality of life? So really that is the question that gets answered in the guideline once it's time to formulate recommendations. Now, in the PICO formulation stage, it's very important to select outcomes that are comprehensive of both benefits and harms for the patients, and these are patient important outcomes. So that conversation should be part of the panel's decision-making process. What are the outcomes that are important to patients, and how can we rank them accordingly? And think about the outcomes you need to make a decision, not as what is reported in the literature. Oftentimes I hear guideline panels say, oh, we don't have any information, there's no published research on this outcome, we're not going to include it. That prevents, or it takes away the opportunity for all of you or for the panel to say, this is a critical outcome for patients and for us. We really care about this outcome, but there is no published evidence that we found during our systematic review that informs this outcome for decision-making. Therefore, we would really encourage research to be able to be done so that we have this outcome, we have data on this outcome to update our guideline in the future. So please do include all relevant outcomes. If you conduct your search and you don't find anything, that is a piece of information that is very, very important for the guideline process. This is a little graphic that shows this process to identify all relevant outcomes and rank them. The panel, again, does this process with the help of the methodological lead, who is this unbiased person, can kind of guide the panel to make these decisions. So the different levels of outcomes are critical, those that are critical for decision-making, important but not critical, and of low importance. And really we focus on critical and important outcomes during the panel's decision-making process. Ideally, keep, per PICO question, keep less than 7 outcomes. Past 7 outcomes, it's very difficult for the guideline panel to understand or compile or synthesize all of the data. So really keeping it to 7 and under is very important. And the certainty of the evidence. So once we do the systematic review, how certain we are of that estimate of effect for that particular outcome, the quality of the evidence informing that outcome is assigned. And it's very important we have that. And estimates of effect for critical outcomes will be prioritized by the panel when formulating recommendations, specifically when you're selecting the strength of the recommendation. And Dr. Joseph will get into that as well. Assigning the strength of the recommendations based on the lowest certainty, and ranking, therefore, is very, very important, because the critical outcomes are the ones that define what, again, the strength of the recommendation will be. And as you can see on this little graphic, mortality, morbidity, and anaphylaxis are higher or more critical for decision-making versus bacterial count, a surrogate outcome, or a taste impairment. Purpose of systematic reviews to synthesize all of this evidence that I just, or all of these decisions that I just explained, is very important. Again, a methodologist can help you conduct this. This is, I think a lot of people think, oh, systematic reviews, we are not doing any primary research. Anyone can do it. There's specific training, methodology, quality criteria that need to be followed or met to be able to conduct a systematic review that is high quality. Poor methodology or poor selection of studies actually, or not appraising the studies in a particular way, really it's a trash in, trash out process. So it really does matter how you do it. And really the goal is to collect estimates of effect on benefits, harms, other outcomes like patient values and preferences. We can do systematic reviews on that as well. And then assessing the certainty or quality of this evidence. And it's an objective representation of the evidence. There are no recommendations that are provided as part of the systematic review process. Question any recommendations that you see in systematic reviews, because the guideline panel is critical to be able to interpret the results of the systematic review. If they don't have a comprehensive panel or a panel that has conflicts of interest that are managed, other factors for decision making like patient values and preferences, etc., are not included in the process, then you really they don't really have all the information to formulate recommendations. So question any recommendations you see in a systematic review. There really should be a separate or associated guideline process involved for any recommendations for clinical practice. This is just a diagram for you to reference later on how to conduct a systematic review. I know you've had your session already, so I'll keep moving. This is information on how to assess the certainty of the evidence. It's done at the outcome level. So in no part of the systematic review or guideline process are you going to say, this study had this quality of evidence, this study had this quality of evidence. It's at the outcome level. So for the outcome of mortality, the body of evidence had very high certainty of evidence. We are very confident in that evidence. Therefore, as a critical outcome, we can provide a strong recommendation. That's really the framework to use when you're assessing certainty of the evidence for panel decision making. And I'm sure this is something Dr. Joseph will explain as well. There are 4 levels of certainty: high, moderate, low, very low. And again, there are multiple domains that should be considered when you're assigning these, and I will not get too much into this. I think it's important to just say that there are 5 domains in GRADE that are used to assess the certainty of the evidence, which includes heterogeneity, imprecision, indirectness, publication bias. I might be missing one, but there are different domains that need to be assessed to be able to assign a certainty of the evidence at an outcome level. And again, a methodologist who's familiar with GRADE can help you do that. This is a meta-analysis that I found online that might be relevant to your field. I wanted to just present this as this is a statistical analysis within a systematic review. You cannot do a meta-analysis without a systematic review, otherwise you're cherry picking studies and data to run your analysis with. So systematic review precedes a meta-analysis every single time. And you end up with a synthesized statistical analysis of all relevant data. And you're really able to use this forest plot to assess the certainty of the evidence. You're able to look at it and say how similar are their studies, how similar are the populations included in these studies, how wide are the confidence intervals, and using this body of evidence also determine if there's any publication bias as well. So again, it's pretty complicated. I won't get into it, but this is really the base statistical, numerical, quantitative data that the panel uses for their decision making on benefits and harms of therapies, and then obviously diagnostic test accuracy for any diagnostic tests you're evaluating. There are several tables and figures that should be presented to the panel during the guideline recommendations formulation process, which is later on in that flow diagram that I showed you of the key steps in the guideline development process. The panel should understand how big was the body of evidence we retrieved and how many articles do we have now? What are the included studies based on our selection criteria? And can I have a table of all of the studies and their characteristics? So it's very important that that Prisma diagram is published as part of the systematic review and referenced, and if needed, referenced in the guideline manuscript. The study characteristics table is also very important because that lists all of the studies that were used for the guidelines decision-making process. So this could include information on the title, authors, the intervention control, so kind of breaking it out in that PICO format, intervention control, the setting in which those patients were seen, what the patients actually look like, and the outcomes that were collected. And again, this all factors into the certainty of the evidence process as well, because you're able to see, are the are the data that we're combining similar enough, to combine? And if there are any mild differences, should we rate down the quality or the certainty of the evidence? So if there are small differences in the patients that are combined in the statistical analysis, how different does that make the data from the question that we're asking? So it's very important to have this table. And also the risk of bias figure, which is the one I forgot to mention earlier. That's another domain in the grade assessment for certainty in the evidence. This shows you the limitations in the study design or studies, methodological quality, the studies that you're actually including in the process. So this figure is generated in RevMan, which is a statistical software. So it helps you create this figure, and based off of various domains within the risk of bias assessment tool, Cochrane has a great one that we use. It allows you to rate different domains within the risk of bias tool at the study level that is used to assess the certainty of the evidence. This is another meta-analysis that I found that is potentially of interest to all of you. And this is what is called this is a table that was contained within that paper. It's an evidence profile that contains at an outcome level. So remember, using grade, we're assessing all the data, collecting and synthesizing data at the outcome level and assigning a certainty of that evidence at the outcome level for decision-making. I wanted to just show you what an evidence profile looks like, how it's set up. This is really the most important piece that shows up at a panel meeting. So this is really what the methodologist or the chairs put up on the screen and say, all right, let's formulate a recommendation. I think that what you can see in this evidence profile is at an outcome level for that PICO question, all of the data that was synthesized. You don't see any study names. We're not getting into that. It's really a summary estimate at both relative and absolute measures. And then the number of studies that inform that outcome and the certainty in the evidence. For this outcome, frequency of PDPH in obstetric patients within a follow-up of 3 to 7 days. We have 9 studies. The risk ratio for this estimate or for this outcome is 3.27 with a 95% confidence interval of 2.15 to 4.96. And we have a moderate certainty in this estimate. So that's what that means across these 9 studies and 2,500 patients. Panel had no comments. So that's how you read this table. Again, I will, for the sake of my presentation, I will stop there. But moving into Dr. Joseph's presentation, old systems other than grade use this method of using or of saying RCTs mean high-level recommendations, observational studies equal low-level recommendations. And we're moving away from that because sometimes observational studies are the appropriate study design to include as part of your guideline development process. And maybe you're very, very strong about those recommendations based on the quality of those observational studies and the data that you get from it. Therefore, obviously, RCTs have that study design for a reason. They're more robust. There's less bias incorporated as part of the RCT randomized controlled trial process. But we're moving away from that in grade and really thinking about all of the factors for decision-making when we're formulating recommendations. So within this evidence-based medicine framework, what we're really thinking about is not only the data, the balance between benefits and harms, which we collect using the systematic review and the certainty of that evidence, but also patient values and preferences, resource utilization, and equity. So that's a new one that's also being very much emphasized and for good reason. And that's also part of the evidence decision framework. So this slide is the classic grade slide. We have the panel in the middle. We have the PICO formulation process. We move across outcomes to synthesize data, put it into tables, rate the quality of that evidence, and then provide all of this information in those evidence profiles to the panel to formulate recommendations. There are some resources listed on the slide if you are interested, and you can always email me as well. And thank you so much for having me. It's been a pleasure. And please email me anytime. I do have to go to work. It's 8:30 a.m. here, but I'll stay on for a minute in case there are any questions.
Malika, I think I just have one question to you. One thing is you have also included a very important point that we should include all the evidence. That is very important because we should not say that that evidence was not there initially, so we are not including, because that is how we are going to move ahead and move forward with the new evidence. In India, what we can do as the methodologist for the studies, can we use the biostatisticians?
The biostatisticians are a good start, but they're not trained necessarily. They may be, some of them may be, but they're not trained in the evidence to decision framework. So guideline methodology is a separate field than biostatistics because they're really specializing in that meta-analysis, which is just one component of that entire process. So I would suggest that you look for a guideline methodologist, a systematic review methodologist.
Dr. Radhika, yeah, Dr. Radhika, are you there? What about the
I'm there.
methodologists in our country?
Pardon?
Can anybody suggest who are the guideline methodologists in our country?
So I'm in the field of obs and gynae. I think I'm not aware, except for the fact that now I am a certified level 2 trainer for the in-guide methodologist. You know, basically there is a certifying agency at the McMaster University, Toronto. There is an in-guide program that is the international accreditation for the guidelines development. So I have undertaken the training program there, and now I am on to level 3, and I have been certified as a tutor for level 2. So if you ask me, then I can suggest my name. And very sorry to at the cost of sounding extremely immodest.
Yeah, I think
But
Malika's lecture was very
is the first step
comprehensive,
which
and I
is
really
required,
like the idea that patients should be included, because if they don't understand what the guidelines are being made, you know, they should be in simple language. I think that's a good point we should undertake, that the patient should also be, if not maybe initially, but after we made the guideline as a reviewer panel, patient or public person can be part of that, you know, of the guideline review, how they understand it, you know, because now everybody knows, Google's everything. So that's a very good idea. And I think the research methodologist would make a job of making the guidelines very, very easy, giving us everything on a platter. So Radhika, you are in for a good business.
the methodologist could also be viewed as a, you know, a stumbling block because that could be the person who is actually giving you the breaks and you know, telling you to be cautious at various stages. So it's a different kind of a challenge.
These two things
No,
are
Radhika,
really
stumbling
new
blocks
for me.
can be a stepping stone for success also.
Ah,
So
great.
stumbling blocks are always a stepping stone for success. So we should not take them as such. When once we have to make that step forward, we have to accept them.
Sure,
and it was
of
a
course.
wonderful presentation by Dr. Tampika. I think she has to leave for work because even I understand where I am sitting, my family is getting ready for work now.
Thank you, everyone. It was my pleasure being here. I really appreciate being given the opportunity to speak with you all.
I'll be getting in touch with you.
Absolutely. Feel free to email me. My email is in the presentation. All right. Have a good day.
Thank you so much, Malavika. Thank you for sparing your
Thank
time.
you.
It's a
Thank you
pleasure
so
having
much.
you here. Yeah,
You
thank you so
too.
much.
Bye-bye.
Bye.
I must thank the speakers and the esteemed chairpersons for this wonderful session, and all of us were moved to our seats. So moving ahead to our next session, we have 3 stalwarts of OBGYN field of India as our esteemed chairpersons in our next session. So we are really thankful to them for gracing today's webinar to enlighten us with their wisdom along with their most enriching experiences. So first, I would like to welcome a very enchanting personality, Madam Dr. Jaideep Malhotra, past president of so many organizations, FOGSI, Aspire, IMS, ISAR, and Madam is also holding present president post of SAFOMS and ISPAT. A very dynamic and innovative personality Madam has been credited with many firsts in the field of ART, and Madam has received many awards, including Atmanirbhar App Challenge 2020 for iMoms app. Past Vice Chair ICOG, Madam is also Editor-in-Chief of FOGSI and FOMS journals and many books. I welcome you, ma'am, to the virtual dais as a chairperson of this session.
Thank you.
Next, we have a very respectable Professor Ambuja C. Ma'am. Madam is patron of Hyderabad Menopause Society. Madam is also retired HOD OBGYN Osmania Medical College, Hyderabad, and at present, Madam is visiting Professor Savita University, Chennai. Madam has been President IMS 2021-2022, and Madam is presently Research Committee Chairperson FOMS 2021-2023. Madam has been faculty and resource person of National Board of Examinations from year 2001 till date. And Madam is also Treasurer SOMI, All India Vice President FPAI, and peer reviewer of journals Jogi, JMH, MRIMS Journal of Health Sciences. Welcome, Madam, to the virtual dais. And finally, Dr. Sheila Mane, ma'am, whom all of we call as PPH Lady of India. Madam is ICOG Vice Chair Elect 2023, and Madam has been Vice President FOGSI 2014, Chairperson Safe Motherhood Committee 2008 to 2013, President BSOG, President BMS. Madam has been National Facilitator Adolescent Health WHO and ICOG Governing Council Member 2020-2022. Madam is also a reviewer for Jogi and President ISOPA Bangalore chapter. So, Madam, I welcome you to the virtual dais. And now I hand over the session to our esteemed chairpersons. And may I request Dr. Sheila Mane to kindly introduce Dr. Joseph Matthew, our speaker. Sheila Mane, ma'am.
Yeah, thank you, Ranjana, for that kind introduction. And it's a pleasure to be there as a faculty, as a chairing the session in this very important academic session of research methodology. And I think it's a real learning for all of us, you know. And Lakshmi has taken it so seriously, and, you know, her ideas, I must congratulate her. Now, Joseph L. Matthew is a professor, pediatric pulmonology and head pediatric pulmonology division, Advanced Pediatric Center, PGI MER Chandigarh. And additional responsibilities are, he is a PI, ICMR Advanced Center for Evidence-Based Child Health, Coordinator DST, Biomedical Instruments and Devices Hub. He is a member of GIN Board of Trustees and a founder chair of GIN LMIC Working Group. So it's my pleasure to invite and welcome Dr. Joseph to deliver his talk. Welcome you, Dr. Joseph.
Thank you very much, Madam. I hope the first slide is visible.
Yes, yes, yes.
Okay, excellent.
Yes, we can.
So thank you. Thank you, Dr. Radhika. And hello to all the old friends and to the new friends as well. So I think Dr. Malavika has set us the tempo because she has explained to us how an evidence-based guideline works. And I hope that by now everyone has realized that in this gathering, probably other than Dr. Radhika, everything that we have done so far in the name of guidelines has to be unlearned and forgotten in order to actually move towards evidence-based guideline formulation. Because it's a process and not just the product which is important. So Dr. Malavika nicely explained to us that, and I will just piggyback onto that using her own example so that we can understand a little bit of how we go from the evidence to the decisions. Now, to begin, what does the evidence look like? You must be familiar with this movie and book which talked about 50 Shades of Grey. So in the same way, there are 50 shades of evidence. Now, some years back, probably at the bottom of this pyramid, expert opinion, consensus statement, position papers, group of experts gathering together over a weekend, whether it's representing FOGSI or ICOG or whatever, sitting together, deliberating, applying their knowledge, doing a little bit of literature survey, and by the Sunday evening before you catch your flights and trains, you have what is called a guideline. My society is the same. Indian Academy of Pediatrics does that regularly. That is not a guideline. That's the first point to remember. The second is, when we look at the evidence hierarchy, as you go up this pyramid, you find that the quality of evidence increases. And the reason for that is that the risk of bias decreases as you climb up this pyramid. So it is easy to understand why RCTs are the best form of evidence. And SR, which is a systematic review of RCTs, then becomes a superior form of evidence for interventional questions. And on top there in the little triangle is a blue circle, which is the logo of the Cochrane collaboration. Cochrane systematic reviews are done much more rigorously and methodologically more robust than ordinary systematic reviews. So they become the best form of evidence for most of the intervention questions. Now, why we're talking about this is in the context of the example that Malavika presented, which is a topic I think which is important for the audience today, is acupuncture for menopausal hot flushes. Now, I know acupuncture is not a big deal in India, but just imagine that it is, and your group or your expert group is required to produce some kind of a guideline recommendation on whether we should recommend acupuncture for menopausal hot flushes. Again, this is just an example, so don't worry too much about the relative importance of this question for you. I'm sure there are much better treatments than acupuncture, but let's just take this for example. Now, it is easy to understand that if we went by the traditional guideline development method, and there was some evidence to show that acupuncture is really a useful treatment for this, traditionally we would have sat over a weekend, some 30-40 experts would have got together, some studies would have been sifted and looked at, and by the end of the day, we would have come out with a recommendation for or against, or with some kind of conditions attached to it. But thankfully, there is the highest form of evidence available, which is called a Cochrane systematic review on this very topic. Now, I've tried to look in the next slide here, if you can see it. This is a summary conclusion from that particular systematic review, and it says, we found insufficient evidence to determine whether acupuncture is effective for controlling menopausal vasomotor symptoms, or basically hot flushes. Now, those who are anti-acupuncture would say, look, the Cochrane review supports exactly what I'm saying, and therefore we cannot recommend it. Those who are kind of on the fence kind of a thing will say, yeah, but it only says that there was insufficient evidence. There is absence of evidence, which is not the same as evidence of absence of an effect. There is a little play of words over here. So the absence of evidence of an effect of acupuncture is not to be equated or synonymous as the evidence of an absence of effect. So that could be a purist approach. The others might actually look deeper and say, let's actually look at the evidence and see what the evidence is actually telling us, rather than looking at a single line conclusion from the 30 or 40 page systematically. So let's look at the evidence. Now, this, thanks to your systematic review lectures done previously by Dr. Radhika and others, is what a forest plot looks like. So this forest plot is comparing acupuncture versus sham acupuncture, which is the best form of placebo which can be given, for a single important outcome called hot flush frequency. Now, as a non-expert in the field, I don't know if this is an important outcome, but I'm guessing that hot flush frequency must be important to the patient and therefore also to those who treat this condition. Now, you will remember from your forest plot lectures that diamonds which cross this line of no effect basically mean that there is no significant difference statistically between the intervention, which is here acupuncture, and the comparison, which is sham acupuncture. And this is what basically this is showing in terms of the mean differences. In terms of the frequency, we find that there is no statistically significant difference whether you used acupuncture or you used sham acupuncture. In the same way, for the second important outcome of hot flush severity, again, there is no statistically significant difference because both these interventions, the effect is crossing this line of no effect. When we say no effect, what it means is that there is no statistically significant difference in the outcomes, whether you use acupuncture or sham acupuncture. Going a little further, if you looked at the quality of life scores, very limited data, 1 or 2 trials only, again, the diamonds are crossing that line, which means that there is no difference between acupuncture versus sham acupuncture. So from this much evidence, we can reasonably conclude that acupuncture is not effective. That would be the simplistic way of looking at it. But the purist's way of looking at it would not be that. It would be that there is no difference in effect for these 3 outcomes: hot flush severity, hot flush frequency, quality of life of the patients undergoing all this, there is no statistically significant difference between giving acupuncture versus sham acupuncture, which means either both are equally ineffective or both are equally effective. This is completely different from saying that acupuncture is useless from the purists or the methodological perspective. Now, is that enough for us to base our decisions on? Probably not, because I'm sure in this house, people would say that acupuncture and all we don't need because there are certain effective therapies. And one of them I understand is this thing called hormonal therapy or HT. So let's look at how acupuncture compares against HT. So here are the forest plots. You can see that the 2 diamonds and the 3 diamonds are now on one side of this line of no effect, which means that there is a statistically significant difference now in the hot flush frequency, and it favors using hormonal therapy. That's helpful. Next slide shows the same thing for hot flush severity. To our bad luck, you see that there is one trial which is showing some benefit in terms of hot flush severity, but one trial is showing no benefit, and the pooled effect is not showing any difference in the hot flush severity between acupuncture versus hormonal therapy. That puts us a bit of a problem, because one outcome is in favor of hormonal therapy, the other is not in favor. It just shows both as equivalent. Now, what do we do? The third outcome is only one trial, very few patients, hardly 40. And that is showing some statistically significant benefit on the quality of life. So this creates now the problem for our guideline development group. What kind of a recommendation can we give based on this? If we looked at the evidence alone and we didn't factor our own personal practice, our own biases, our own expertise and things like that. There is one more twist to this thing. When you look at acupuncture versus doing nothing, which means don't do anything, just leave the patient as it were, then it seems that small trials seem to show that acupuncture actually has a lot of benefit. This diamond is now entirely on the left of the line of no effect, suggesting a statistically significant benefit. And for this outcome of hot flush severity, even more dramatic benefits with acupuncture as compared to not doing anything. Quality of life, only one trial, 30 participants, so not really very significant. Now, how do we make sense out of all of this if we had to frame some kind of a recommendation on the simple issue of whether acupuncture can be supported or recommended by the prestigious bodies that all of you are at? And that is the challenge, because this is what the evidence will look like. The evidence will not be, some one randomized controlled trial done somewhere. Okay, it's been done in my college. I am the PI, so therefore it's the best form of evidence. My personal practice, I've treated hundreds of patients with this acupuncture. It seems to work. That is not what will go in. It is this body of evidence which will be used to decide whether or not we can recommend acupuncture or reject it as a recommendation. Let's look back at the conclusion. Now, this statement, which I read out to you previously, that there is insufficient evidence to determine whether it is effective or not, makes sense. And why is the evidence regarded insufficient? One, there were 5 or 6 trials. They had different methodologies. There was a lot of heterogeneity, which means differences in the way the results showed up. There was some benefit with hormonal treatment, some benefit with acupuncture versus doing no treatment. So on balance, the authors concluded that the evidence was insufficient to determine. Now, a guideline panel cannot sit back and say, the evidence is insufficient or the evidence is absent. So this is what I'm going to recommend. So therefore, all you people are going to read my guideline, do whatever you like. If you want to use it, use it. If you don't want to use it, don't use it. That is not an option. Even in the evidence being insufficient or the quality of evidence being insufficient, we have to end up with some kind of a recommendation. And this is how we go about it in the next few slides. First, when you get a systematic review, by default, a Cochrane systematic review is taken as a very high level of evidence because of the methodological rigor which goes into it. But before you plunge and look at the data from a Cochrane systematic review, please see whether it is current. What is the meaning of current? Is it up to date? And by up to date, we're not interested in its date of publication alone. What we're interested in to see is whether it has captured the entire body of evidence which is available on that particular PICO question to produce the answer to that question. Now, if this menopausal hot flushes is a topic wherein every week trials are coming out, then even a 2-year-old Cochrane review might not be regarded as current. Just like COVID. In COVID, data was coming up every day, every week, every month. So even a 3-month-old systematic review was probably outdated. So for this topic, currency is going to be determined by whether there is a likelihood of more evidence, more randomized controlled trials, more data being available since the publication of that. If there is this possibility and the systematic review is not current, no point in using it. You've got to either update that review or undertake a new review altogether. And this is what your guideline methodologists in your group will have to do. On the other hand, if the review is current, look for its methodological quality. If the quality is good, and there are tools which are available, checklists which are available to look at the methodological quality of a particular systematic review, if you are satisfied with the quality, by quality we don't mean the way it has been written and the beautiful bars and charts and things, we mean methodological quality. The confidence that we have that what the authors are actually describing and emphasizing can be believed and considered as the truth. If they put in their own errors, methodological errors, their own subjective biases, and that is going to take us away from the truth, and that would be a review which is not of high quality, and therefore necessitate that we either update that review or undertake a new systematic review. The third step is where you look at the PICO question which you have framed for your guideline group and see whether that question can be answered by this systematic review. So that is the importance of framing a question in the PICO format, and Dr. Tempe highlighted that was very nicely. Now the question is not, shall we recommend acupuncture or not? The question will turn itself on its head. If you use acupuncture versus the other intervention that is of interest to you, what would be the effect in women with perimenopausal hot flushes on issues like hot flush frequency and severity, quality of life, so on and so forth. That is a question which a systematic review can ask. A systematic review cannot answer a question framed as, shall I recommend acupuncture for hot flushes? That's a decision question which we have to frame based on, in part, the systematic review evidence and some other things which I will talk to you about. So understand this. Literature, evidence, trials, systematic reviews cannot answer decision questions of what should I do, what should I not do, what should I recommend, what should I not do. It can only answer research questions or clinical questions that in this so-and-so population, if so-and-so intervention compared to other comparator is used, what are the effects going to be? From that, we have to decide whether the systematic review findings are applicable for the question that you have. If so, you extract the evidence, look at the evidence data exactly like I showed you with those 7 or 8 forest plots that I highlighted before. So, to do this, is it feasible? Now, this methodology is something which I have recently published in the Indian Journal of Pediatrics. The article is currently available online. I will share with you in your chat group, so send it to Dr. Radhika. Your group can use exactly the same methodology. So it is now published, so it is easy for you to piggyback and say, this is a well-recognized methodology, and you can look at it and use this. It's very, very current and recent. So in other words, when you look at a piece of evidence, first decide if it is robust, that is methodologically high quality, and whether it is current. If it is current, does it answer your PICO? If not, do a fresh systematic review, and a new team will have to look at it. If it is current, if it is robust, it answers your PICO. Even now, your work is not complete. You now need to do what is called grading. Now, this grading of evidence or quality checking of the evidence is for your PICO. Previously, we were looking at the methodological quality of evidence or a systematic review as being robust or otherwise for their PICO. If the authors had a PICO, we were checking to see whether their methodology is robust for the PICO that they have framed. Now you're doing grading using the grade approach to look for quality checks for this evidence to be plugged in to your PICO. So things will now vary, exactly as Dr. Tempe highlighted to us, that Saudi Arabia and Switzerland, using the same piece of evidence, when they did the grading, they came to entirely different conclusions. Why should that happen? It's the same evidence, the same systematic review, so the same robustness, the same degree of currency, but it is the grading which decides whether or not it will fit to your PICO question. And if it does, based on the grading approach which you showed, which means every outcome in the systematic review has to be graded against 5 criteria if they are an RCT-based systematic review. And then you have to look at whether this thing can be plugged in to your evidence to decision. And that's the point I'm going to talk to you about in the next 15 minutes. So you might remember I had 2 topics to cover of 15 minutes duration each. So the first one is kind of done. And so I will just flow into the second one so that it is easier for us to understand. So this is what your PICO for your guideline group will be looking at. And the framework is simple. There is an intervention, there is a comparison, there is a health problem or a problem and a population. So once you put all those things down in detail, your question now no more is a question that I framed on slide number 1 or 2, which was, should I recommend acupuncture? The question now becomes, should acupuncture versus this versus what is critically important and for your group to decide. Are you interested in acupuncture as an alternative to hormonal therapy? That's a different PICO. Are you interested in looking at acupuncture as versus no intervention? Entirely different PICO. Are you looking at acupuncture versus hormonal therapy or no intervention? That's an entirely different PICO. But a comparison has to be framed because a guideline recommendation, unlike our current understanding, is not a do and don't statement. Do this, don't do that, can do this, cannot do that. That is not what a guideline recommendation is. The guideline recommendation is a choice which is being offered to the stakeholders of what would happen if they implemented intervention versus the comparison that you're talking about based on the current evidence which you have appraised for quality and graded as per the grade approach. So this kind of a question which can frame a recommendation. We can't frame a recommendation or should I use acupuncture, should FOGSI recommend acupuncture and so on and so forth. Now what goes into deciding whether acupuncture versus the comparison, well, which of these 2 or 3 that I've listed you want to look at is your choice. It has to be decided a priori and then the guideline group sits together and frames the recommendation. Now, the 12 things which go in are first a statement of the problem. Is the problem a priority? Yes, obviously hot flushes are a priority, but that's not the issue alone. Is the need for acupuncture in hot flushes, is that a priority? And the reasons for it being a priority usually are research evidence which show that hot flushes is a very big problem. The common things that are all being done are not really very effective, or maybe they're effective, but some people don't respond to that. Or there is a wide variation in the way this thing is practiced, or the therapy which is currently used is very, very effective, but it has horrible side effects which cause people to drop compliance, or they don't take it, or they feel fed up with it. That makes the intervention of acupuncture possibly a priority. On the other hand, if in your healthcare system and your healthcare setting, acupuncture is not a priority problem, then we don't even need to waste our time and energy trying to frame a recommendation or look at the evidence for that particular issue. Let's pretend for the next 10 minutes that hot flushes is a very big problem in the settings that you work in, and acupuncture for some reason, either by virtue of its efficacy or by virtue of its relative safety or by virtue of the problems associated with the current treatments that you all give, somehow is a problem of high priority. Then we can go ahead to step number 2, which is to look at the desirable effects of implementing this intervention. And that is easy. You look at the research evidence. Thankfully, we have the research evidence from the Cochrane review, assuming that it is current, of good quality, answers the PICO that you and I are interested in this particular guideline recommendation panel. Then we look at the desirable effects of implementing that intervention based from the evidence, if it's available, if not, from the additional considerations which you might have from non-RCT based intervention. And just like we look at the desirable effects, we'll also look at the undesirable effects. What are the undesirable effects if you use acupuncture? And this is not just the side effects or the adverse effects of the intervention alone. There are other considerations like it is a skill. So an acupuncture delivered by an expert in the field would be completely different from delivered by a novice in the field. And similarly, acupuncture which is delivered by people who have the requisite training would be different from those who don't have the requisite training. There is a learning curve with all the skill-based procedures and all that, which makes acupuncture probably different from hormonal therapy, which only requires a prescription and some monitoring and follow-up. There is no real hand-based skill which is involved in prescribing medications. So the undesirable side effects or the undesirable effects of any intervention would be the side effects, adverse effects, and also to some extent, the problems which are associated with implementing or delivering. Imagine the amount of extra effects that would be required for biomedical waste disposal, to make sure that the needles don't go too deep inside and create bleeding and so on and so forth. These are the undesirable effects probably of acupuncture. The fourth thing which goes in is, how certain are we about the evidence which has looked into this? And this little figure, which shows the judgments as very low, low, moderate, or high, this is what the grading of the evidence results in. So in grading of the evidence, you would look for each outcome, each study, and then look for all the outcomes across all the studies. And together, you will come to one summary kind of an estimate on whether for each outcome, the grading of the evidence is low, very low, moderate, or high for that particular outcome. And then when I got a bunch of 3 or 4 outcomes of the kind I showed you in this perimenopausal hot flush business, you look at the collective data, collective evidence across all those outcomes, and then determine whether the overall body of evidence coming from that comprehensive systematic review is fitting one of these things. Obviously, higher the grade, more confidence are you in the estimates that are being reported, more confident will you be that if the guideline were to recommend that intervention, the desirable effects would have been achieved as compared to the others. Then, the fifth point to look at is the values that different stakeholders have for that particular outcome. Now, by stakeholder, we generally imagine, because we are healthcare providers, we think of ourselves as the main stakeholders because we are the guns, we are the top guns delivering the intervention, we are the guns deciding on the patient's behalf, we are the ones who are looking at the evidence and making the guideline, but we are only one cog in the wheel. We are only one cog. There are other cogs in the wheel. The other important cog is the patient. So his or her values and preferences need to be factored in. And then patient and provider are in an ecosystem, which is also comprised by the healthcare system, your institution where you're going to do this, your country or the local thing where all this is happening, your policy-making bodies, funding agencies which are actually going to fund or not fund acupuncture, FOGSI, which is coming in as an important stakeholder. These are the other stakeholders who also need to look at and consider whether their values are the same as in terms of importance from the provider's perspective and the recipient perspective. And there are in this grading approach, there are options given over there, and you as a guideline development group, you have to go through this and pick and circle one of these for your particular question on values. Then the balance of effects. This is easy. There were some desirable effects. There were some undesirable effects. How do we see the balance between them? And this balance is not a numeric balance. It is not a scale wherein there is 1 kg of desirable effects and half kg of undesirable effects. So therefore, the scales are tipped in favor of that intervention. There will be nuances over here, which you will have to sift out at the qualitative level. For example, there may be 3 efficacy outcomes which are in favor of the acupuncture, but there may be horrible side effects, undesirable effects, which weigh against it. And I'm guessing that that could be the problem with hormonal therapy. Because hormonal therapy, I'm given to understand from my zero knowledge on the subject, is supposedly efficacious, but then there are problems with compliance, side effects, and certain things because of which the clients that you prescribe it to sometimes give up taking it along the way, or some of them are absolutely refusing to take it. So those things will have to be factored in when you look at the balance of desirable versus the undesirable. Then the resources required. And resources generally we understand in terms of money, but remember, it's not the cost of giving the acupuncture alone. By cost of acupuncture, we mean the cost of the needles, the cost of per session and things like that. There are many more things. For people who have to start acupuncture in their clinics, now do you need trained personnel for that? Do you need more time? Because a hormonal therapy prescription takes you 5 minutes. This thing might take you 50 minutes. So that time has got cost. Then people would need to schedule appointments. You need a biomedical waste disposal for those needles. And if there is equipment, their upkeep and maintenance, initial cost, all these things go into the costs of resources which are required. And then, is there certainty of evidence of these resource requirements? Sometimes, like me, if you're talking through your hat, I'm just giving you some ballpark numbers that the cost of acupuncture is, say, 10,000 rupees. These are all estimates and guesstimates. You will need real evidence for the costs because real costs have real numbers and those numbers will have to be inputted. Guesstimates can be completely off the mark. The one point I want to mention here is if you do this in bulk, which means if you're doing acupuncture for one patient, the cost will be probably much higher than if you did it for a number of patients. Now that's easy to understand. The more numbers that you do, the overall costs come down as to doing it for an individual patient. So the cost of a CT scan is 1,500 rupees or 2,000 rupees or maybe 3,000 rupees. That answer is completely wrong. The cost is probably 1 crore if you factor the cost of the machine and the cost of the radiologist, its upkeep, its maintenance and things. But that 1 crore is not for one patient CT scan. When you divide it by 100,000 CT scans, then the cost comes down to 1,000. And that's the basis on which organizations decide how much to charge a given patient so that the costs can be recovered. And those are the costs which will have to be factored in when you decide on resource allocation questions for your guideline group. So it's not saying that, okay, the drug is very cheap, so therefore the resources are low. It's the other things which are involved. Then comes a discipline called cost effectiveness. This is completely different from cost. This is cost being balanced against effectiveness, which means for every rupee that is going into your recommendation, how much is the output in terms of rupees? So it's very easy to say when I put in 10 rupees, this is what I get in terms of health outcomes and patient satisfaction and all that. But all of that being converted into rupee value is the domain of health economists. So mostly we won't have cost effectiveness data for most of the intervention that we talk about. So we will end up with the last option on this slide, which is there are no included studies. And then you start doing some additional calculations, back of the envelope calculations, guesstimates, and say that these are all not robust data. So we could be way off the mark. If possible, put confidence intervals and ranges to show what the cost effectiveness could or could not. But it is always safest to say there is no data on cost effectiveness. So everything that we are saying could be off the mark. Then equity. Interventions that work very well, but are expensive and only available in tertiary care centers and only available in cities are liable to create disparities in equity. Interventions which are like prescriptions of tablets and things like that, which can be given across the board to everybody in all settings, not very, different in terms of affording class versus not affording class and things like that. Those recommendations are more in favor of equity. So things which foster better equity are more likely to be recommended by guideline panel groups as opposed to the other. Acceptability. Now, acceptability to whom? Those 5 or 6 categories of stakeholders that I talked about, an intervention or a recommendation. Both should be acceptable to the key stakeholders, otherwise this thing doesn't really work. And you have prime examples of this when the AIDS epidemic hit the African countries and condoms were being shown as evidence-based solution for it. Some African countries readily absorbed this, some did not. Because in those settings, when the female partner insisted the male partner should wear a condom, the male partner took it as a sign of infidelity on the part of the female. You see the catch, whereas the problem is the other way around. The female is insisting on the condom likely because the male partner is showing infidelity. But when she insists on it, it's putting in the male partner's head that my wife is unfaithful. So the whole condom thing flopped in countries like Uganda and things, even though they were evidence-based and things. So acceptability is a very key important thing in this whole process. And lastly, of course, feasibility of how easy or how difficult is it to implement a particular intervention, and what would be the feasibility of recommending it, and what would happen downstream if you did it. When you've looked at all these, so then you are able to make this table, which is called the summary of judgments. Don't look at this in very great detail. This is all available online. So on the blue columns on the left-hand side are those 12 criteria that I talked about. And in the columns on the right-hand side in white are the options. So you keep circling after much deliberation, discussion, not just guesswork. The guideline panel has to come to some kind of a consensus or some unanimity on this particular thing. And this is how it would look like at the end. Then what do you do? Then finally you decide based on this, what kind of a recommendation that you. There are 5 broad options. Recommendations could be for the intervention. They could be against the intervention. Among the for and against, there could be strong recommendations, weak or conditional recommendations. Strong recommendations are those which are backed up by robust evidence, current evidence, high quality evidence. Grading is showing that they are still relevant to your PICO, and you're working through evidence to decision framework tables, gives you the confidence as a guideline development group that were this recommendation to be disseminated and implemented, the beneficial effects are going to outweigh the non-beneficial. If you have that confidence, you give a strong recommendation. You don't have that confidence, you give weak recommendations or conditional recommendations. Yes, this intervention will work, but if this were done, or in the hands of a person who's trained to give acupuncture with great skill and so on and so forth. And right in the middle is a recommendation for either the intervention or the comparison. This happens when you're sitting on the fence, when you cannot decide based on all the criteria that I've said, whether to favor one or the other. And then the guideline development panel gives its recommendation for either stating in these terms, if you're a practitioner who has got the skill and uses acupuncture, please continue to do so. If you are somebody who doesn't do, there is no need to switch your practice and start using it. This is what the middle thing is. So this is how a guideline recommendations panel would look like. There will be a simple 2-3 sentence statement, which is a recommendation. There will be tons of justification so that everyone knows that you've been transparent. There might be subgroup considerations, which means acupuncture seems to work in a certain subgroup of people with menopause and hot flashes. Identify those and list it out. There might be implementation considerations, like if you're using acupuncture, remember the learning curve, remember to wear gloves, remember to dispose the wastes appropriately, so on and so forth. Then the guideline development group should also wonder, if we did this recommendation in favor of acupuncture or against, depending on which way you lean, and this recommendation got implemented, how are we going to know the outcomes in the community, say in 1 year's time or 2 years? What tools are we going to use to monitor the implementation and the outcomes of this? And more often than not, there will be some research gaps identified. Pick the guideline group, then we'll put up to your stakeholders and say, look, these are the gray areas. Please go and find evidence on this so that when we update the guideline recommendation, we have much more robust evidence. I think that in a nutshell, in 30 minutes is what I can cover on how we look at evidence, make our evidence fit or not fit the PICO questions that we have by doing the grade approach, and then working through this evidence to decision framework to actually translate evidence into decisions, which can be then framed into guideline recommendations for the stakeholders that you are interested. Thank you very much. I will stop sharing my screen and take up any questions you have.
Thank you so much, sir, for that crystal clear, brilliant presentation. May I have the comments of Dr. Jaideep Malhotra, ma'am, please?
Thank you, Ranjana. And first of all, congratulations, Lakshmi. A very much needed webinar, and I think we need many more of these. Must congratulate the speakers for all the 3 talks. They have been fantastic. But I think we are far away from there's a huge learning curve, especially where our country is concerned, whether, research is concerned, interpretation, implementation, and then, the guidelines and the recommendations are concerned. But it's a really great beginning. I myself had been involved, in 2 international guidelines preparation. One was the WHO terminology, which went on for 6 years. And then we had these international guidelines on PCOS, which was basically driven by the Australian group, but ultimately the whole world almost endorsed them. Now, for that also, we worked for almost about 16 months. And in both of these, more than 70 countries representatives were there. There were many, groups working on different areas. And it was a phenomenal exercise. For me, the first one was like an eye-opener because we had no exposure to this kind of work anywhere. By the time, we reached the PCOS, it was, I was in a much better state to understand actually what was happening. And that's something which is important because in our country, we take guidelines very, superficially. And we feel, anytime anybody who feels, oh, this is what has to be followed. It cannot be done like this. There's a whole system and process, which this particular webinar has given a real insight. And this process has to be very systematically followed. Plus the last part of Dr. Matthew's talk on, how to implement, because making of a guidelines is a very complex procedure.
And if at the end of this whole exercise, if people are not really going to follow them or use them, this is a futile exercise. So endorsement from the various organizations, from the government, from the NGOs, involvement of the patients, all this is very important part and parcel of making of a guideline. And today this webinar has really thrown a great insight, and I feel we must do many more of these, Radhika, because unless and until people understand, it's we need to be at par. I mean, I feel sometimes so I would say low when I move in the international circle and say, oh, my country, like we have so many numbers, but where is our research? Where are our RCTs? Where is, the data, which we are like a drip country, data rich and information poor? Where is all that? And that should be part of our education system. We are not really taught in a post-graduation like that. So I think it should come even earlier. So I must congratulate each and every one of you for a very fantastic, crystal clear, very lucid, and very simply explained talks. Thank you so much. I've had a really wonderful experience. Thank you, and congratulations to each one of you.
Thank you so much, madam, for your pearls of wisdom and words of appreciation. In fact, all the 7 webinars which Dr. Lakshmi madam and Dr. Radhika ma'am have planned have went very well and were very informative. So hats off to them, and definitely they need a round of applause. And now I would request Dr. Ambuja ma'am to kindly give her comments. Ma'am, please unmute.
Yeah, good evening, everybody. And I congratulate, first of all, Dr. Lakshmi and Radhika for attempting to choose such a type of subject into a series of lectures to be given. And Dr. Matthews, it is really wonderful and crystal clear presentation it is. And you have given so many inputs for everybody. That's about the type of recommendations, how it should be. More than anything, in such a complex thing to prepare the recommendation itself and how to implement that also you suggested, it's really great. One thing, as Jaideep said, we have to introduce all these things into the curriculum of the undergraduation. That's what is necessary. I think all the universities are making an attempt to do it. Maybe we'll be successful in coming 10 more years. Actually, I was introduced into the Jogi first by M.N. Parekh. What he told, an editor, if can read your comments and understand your recommendations, then it is a helpful review. That's what he was telling. So to understand that, it is very, very difficult, and to make it, and such a wonderful program it is. Thank you making me one into such a program. Thank you very much, Matthews, and thank you, everybody.
Thank you very much, ma'am, for being with us always.
Ranjana?
Yes, ma'am.
Just a request to all of who are participating in this study that we have been doing from the South Asian Federation of Menopause Society and Indian Menopause and all the gynecologists of and even the medical practitioners of India, they are invited to this survey on the relationship of menopause to metabolic syndrome, which is very much required, and we need our own data because so far we just don't have our data. We are extrapolating studies from done in the UK and USA on the populations there. So please participate in this study. This is a very simple study which can be taken even on the Google Forms even. So request to all of you to please disseminate this form which is there in the group at the bottom. So I'll be sending to all of you. And congratulations to Radhika and Lakshmi Shrikhande for this webinar, and all the participants who have been wonderful, Dr. Matthews, Dr. Dipali, everything, they have been really nice. And Ranjana, to you also for being a very good I think boss was
Madam, request all of you to stay back, please, because we also have Dr.
Akhilesh
Dr.
Ramaswamy,
Akhilesh.
yeah.
Yeah.
So let me introduce Dr. Akhilesh Ramaswamy. We have a very young dynamic researcher, Dr. Akhilesh Ramaswamy, who is Assistant Professor Dentistry at JIPMER, Karaikal, and who is Chair GINLMIC Working Group 2022-24, member GIN Implementation Working Group, transdisciplinary researcher and design thinker. He has an ardent interest and expertise in data analysis using R, and he is advocate of driven decision making and behavioral science-based approaches for public good. He is also passionate about systems approach to implementation of innovations in healthcare. So let us listen to Dr. Akhilesh, please. Dr. Akhilesh?
Yes, am I audible?
Yes, yes, sir. But you are not
yes.
visible.
Yeah.
Yeah, welcome, sir.
Yeah, thank you. When we had this discussion with Dr. Radhika about how we are going to take it up, the idea was to keep it into very simple and biteable chunks. The end of it, actually, there have been some nice points which have been introduced by Dr. Malavika and expounded by Dr. Joseph as well. One important aspect what I wanted to highlight was just an extension of what Dr. Joseph Matthews has actually taken in. There are 2 points, to be honest. There are only just 2 small concepts which I wanted to add up to this. One thing is about the complexity in implementing the clinical practice guidelines, which was the last part of what Dr. Joseph had talked about, as to how there are challenges in how an evidence gets translated from the bedside to the bedside. And there have been some studies which have kind of, tracked the timeline, and average time it takes for a study to come from the bedside to bedside is around nearly 17 years. And around only, 10 to 14% of the research is what actually reaches the, it just translates into practice. So this is actually a very small number considering the number of studies which are published and everything. One challenge what happens with implementation is what Dr. Joseph Matthews has already mentioned, like taking into account the pull factors, taking into account the the concepts and the barriers and the facilitators which may happen at the end of the road, or in the last mile problem what we have. Because most of the time the decision to start exploring a concept or exploring a topic for guideline development, or actually deciding on the implementation principles are all taken at a higher level. Whereas when it comes into the implementation is actually an end of the mile problem, or it's actually at the frontline workers problem. So there is a big gap between what is decided at that level, the information what is available to them, and downstream what is happening at the at the front line as to how it is implemented and everything. And the other aspect what we need to remember is about the outcomes what we talk about. The outcomes what we talk about when it comes into a clinical research is totally different from the outcomes what we talk about when you're talking in terms of implementation of a clinical practice guidelines. Understanding this difference is important, otherwise the teams may end up setting up goals, or setting up evaluation parameters for implementation, which may be aligning with the research goals rather than the implementation goals. So that is a very important thing that I wanted to say. And the other aspect is in a country like India, where we have an opportunity for actually generating a lot of data, what we lack is actually organizing the data or to collating the data at one point. There are some countries, only very few countries have been able to implement it in practice, where they're able to collate data over a long period of time, somewhere around 20 or 30 years down the line and everything. But I think this is something what a country like India should put in, because considering the technological advancements what we have, there is a very good possibility and an opportunity for a lot of associations and clinical practitioners to actually contribute to something of a registry-based system, which should be helping in strengthening the guidelines per se. That will also help in generating data at the local level, which is what we are lacking at the moment. Most of the time, we are forced to take up studies or guidelines which are based on, studies which have been originated in other countries. The other aspect, what we really need to remember with respect to guidelines is how easy it is for a general practitioner, somebody who's into clinical practice in their day-to-day life, where research is not their, usual repertoire, where research is not their usual, daily routine, stuff. So how do they read the guidelines? How do they actually understand it? How do they implement it is also something that we need to understand. So for this sake, apart from the points which are already discussed about including this in the curriculum and everything, one important aspect what we also need to take it up is the guidelines must have precise indications as to how it could be implemented, perhaps with some expounding examples, with examples which are relevant, which are actually relevant to the local scenarios, which would help in easier interpretation and implementation of those guidelines. That's number one. The second thing would be for them is to have a system of evaluation where they should also have a way to give feedbacks on those barriers from downstream to the upstream, which needs to be collated, and then again it has to be incorporated in the next cycle of guidelines. These are the two things which we need to really implement when it comes into the solving the last mile problem with respect to implementation of guidelines, which is a very big challenge. And the other aspect is to also have the guidelines also have, when it comes into WHO in the recent times, they have started incorporating behavioral science concepts into most of the implementation. That means, it's basically about what Amazon and everybody does. They have a way of actually finding out your purchase habits and everything. They know exactly what's going on. And most of their strategies of, presenting their products to you will be based upon those research. So we also have an opportunity of using those kind of researches with respect to implementation, as well as to how it could be, how it is taken up by the practitioners, how it is actually taken up by the patients as well, the relatives, what are the barriers, what facilitates it, what makes it better, and everything. So this is something that we need to really start incorporating. That's part of the implementation framework which we need to take into, because rationality is not something what all humans have. We are basically irrational beings. So at one point where we're talking about evidence, the strength, and all that stuff in the quantitative manner, at the end of the day, there is a human factor which comes into play with respect to implementation of guidelines in the decision-making processes, and as to how it is actually interpreted in real world, or how it is actually work, how is it working in the real world. So that would also require us to use novel methodologies, or something what they call as pragmatic trials, where we speak about evidence from the real world rather than sticking on to in a very controlled as a controlled trials. Yes, they have a very high evidence, but they also have a necessity to do pragmatic trials as to collecting evidence from real world scenarios. One of the ways what we could do is the registries, or one of the ways of actually having data which could be pragmatic and which is based on real world information. And there could also be trials which are designed within another trials, which could be designed on day-to-day hospital practice and such. So these are the practices which we really need to do and strengthen at health policy and a systems research level for us to actually have a more I would say streamline the workflow with respect to from evidence to decision to implementation, and then the cycle just continues. So this is the message that I wanted to give. One is to focus on implementation. The other one is to actually make those implementations implementable at a cost, which is actually affordable. In a country like India, cost is a very big factor. So if you have an intervention which cannot be used by majority of the people, then it will not be adopted. It's going to fail. The other one is to actually use methodologies from decision research and from behavioral design research in order to actually push people to accept the guidelines and to implement them, as well as make even the patients, complaints of patients becomes very important with respect to success of guidelines. So for both of these aspects, we'll have to possibly incorporate those concepts in the design of the guidelines per se. So it was amazing to listen to Malavika and Joseph and all the others for their comments. It was actually, I would say that it had kind of reached its goal, because the important thing was to raise an awareness about the concepts of CPGs, as well as implementation and what are the barriers that we have right now. And the other one is to make it in a language and in a manner which is palatable and encapsulated in a manner that can be taken up by anybody. So it was really amazing listening to them. That's it. I'm done.
Thank you, sir.
Thank you for this opportunity. Yeah.
Thank you, sir, for your very practical insight into the topic and your very valuable inputs. So can we have the comments of Radhika, ma'am?
No, I think we have had a very informative session. Thank you all. I think we can call it a day. Dr. Ranjana, I request you to deliver the vote of thanks.
Okay. Thank you, ma'am. Actually,
we at ICOG understand that it's a very long way to go, but at least I'm happy that we have started walking. So very well done. And Radhika, it was a wonderful module. And on behalf of ICOG, I would like to extend my sincere gratitude to you first, then Dr. Malavika, Dr. Joseph Matthew, and all our chairpersons for the great inputs they have provided for this very unique web series that was on developing clinical practical guidelines. So it was a wonderful session. Thank you all. Thank you so much. And looking forward to see you all in our next ICOG webinar. Thank you.
Yes, thank you, madam. In fact, clinical guidelines gives us confidence in our clinical practice, in our day-to-day practice, and we look up to the guidelines, whether we are doing right or wrong, whether we are sitting in periphery or whether we are in institutions. So they give us the confidence to practice. So thank you very much, Lakshmi ma'am and Radhika ma'am. We have just gone through what it takes to develop a clinical guideline, how difficult the process is. And thank you very much for that insight. And now for the formal vote of thanks. In fact, research methodology is one of the most difficult yet most important subject for today's medical teaching, research, and development. So we salute ICOG Chair Dr. Lakshmi Srikhande ma'am, Vice Chair Dr. Parag Biniwale sir, Secretary Dr. Ashok Kumar sir, and series convener Dr. A.G. Radhika ma'am for taking up this challenging webinar series so far with much acclaims and enriching us with all the detailed informative deliberations in each webinar every month. So thank you very much, ma'am. And we are really thankful to President FOGSI, Dr. Hrishikesh Pai sir, Secretary General Dr. Madhuri Patel, Deputy Secretary General FOGSI, Dr. Suvarna Khadilkar, and Editor-in-Chief Jogi, Dr. Geeta Balsarkar ma'am, for their constant support and guidance. And my most sincere thanks to our wonderful guest speakers, Dr. Malvika Tampi, Dr. Joseph Matthew, and our very own Dr. Radhika ma'am, and also to Dr. Akhilesh for their beautiful deliberations. And I'm really indebted and grateful to our esteemed chairpersons, Dr. Madhuri Patel, Dr. Marinder Ahuja, Dr. Ajla Batra, Dr. Jaideep Malhotra, Dr. Ambuja ma'am, and Dr. Sheila Mani, who took their precious time out to enrich us with their interactions and valuable additions to the sessions. So thank you, each one of you. My special thanks to today's webinar co-convener, Dr. Akhilesh Ramaswamy, and my co-coordinator, Dr. Vaishali. And a big thanks to the ICOG team, Nilima, Jignesh, Gauri, and everyone in the ICOG office who work behind the scene so that this webinar can take place smoothly every month. And in the end, thank you all the viewers for your valuable presence makes the webinar successful. So thank you everyone and goodbye.
Thank you, Dr. Ranjana. Thank you so very much for being there for all the webinars and supporting us and holding the fort. So thank you so much.
It's my pleasure and to be with you, and it's the blessing of Lakshmi ma'am also that I am with you in this webinar series. Thank you very much, ma'am. Thank you very much.
Thanks for being there. So we also take this opportunity to say that we take a break for 2 months and we will come back with the next webinar series starting from September. Yeah.
So,
So thank you so much. Yeah, thank you. Bye-bye.
Bye. Good night.
Bye-bye. Thank you all.